hospitalized in the ICU,
Mm-hmm.
and all the image findings showed that they had multiple lobes that were involved with like consolidations, and
Mm-hmm.
so we came up with grade 3, and then what treatment would we give for the pneumonitis is methylprednisolone 1 milligram per kg per day.
Okay. So a couple of things. Would you consider, so for grade 3, would you maybe also think that she might be grade 4 because she's ventilated?
I can't. That's fine.
What's that?
Sorry, I'm not muted.
Oh, that's okay.
That's a possibility. I was thinking that grade 4 was life-threatening. So yeah, with ventilation, possibly grade 4. Yeah.
Yeah. And I think, for these purposes, it doesn't really matter, right? If it's grade 3 or 4, we know that she's really sick. So you're absolutely right. It involves multiple lobes of the lungs. Her oxygenation is very poor. She's essentially in acute respiratory distress. So for the methylprednisolone, are you happy with that dose at 1 mg per kg?
Well, since it's more severe, I would say 2.
Okay, yeah. I think that's probably reasonable, right? So, okay, so then despite the treatment plan from above, she got worse, which is bad. So you want to go with add 5 mg per kg of infliximab?
Yeah.
Okay, so then do you want to walk us through, actually, thank you for that. And I'm going to have team 2, can you go ahead and take on question 3A?
I have the document open if you want me to pull it up if no one's up.
Yeah, if you can share it.
Okay. I think this was the same one that you had in your slide, though.
Mm-hmm.
And we had another one as well, but I think someone else in my team has it open up.
Okay.
But this one was the oh yeah, it's right here. So we did it based off of. Can you see my screen?
Yeah, it's
You can rotate it on.
Yeah, if you can rotate. Sorry, I was trying to rotate my head.
oh no, I lost it.
Yep. Perfect. Okay, cool. Oops. There you go. Okay.
Yeah, so this was our source that we found.
Okay. And then did you trace it back to the original study? Were you able to do that?
I don't think so.
Okay, that's okay. And you may not have had time to do this because, it takes quite a while. So, okay, so this was the, what you came up with. So kind of same thing, right? You wanted to give methylprednisolone 2 mg per kg and then the infliximab 5 mg per kg?
Yeah.
Okay. Awesome.
I am team 1. I have a little bit of a different recommendation for answer 2.
Let's hear it.
We said we should do intravenous immunoglobulin at 2 grams per kg.
Okay.
On day 9 to 13 for 5-day course.
Okay.
And we chose this. We found one reference, and it says that because it has relatively mild toxicity profile as compared to other immunosuppressive agents such as infliximab, cyclophosphamide, and mycophenolate. So we would do that. But that's not the clinical trial. That's kind of a review article that I found. I was about to go do cross-referencing, and I was digging into the references, how they find this information, but I ran out of time.
Yeah, so that's totally fine. And you're absolutely right. So you could also give IVIG. Now, one of the nice things about giving IVIG is that it's cheap, relatively, compared to infliximab, and it's already available inpatient. It's easy to dose, and there's also no need to do like, quantiferon to check to see if somebody has TB, right, or something like that. So yeah, that is absolutely an option, and it's been used before. And there are case reports where it's worked fairly well. So I think either infliximab or IVIG, would be absolutely correct answers. That's awesome. All right, you want to team one? Do you want to take the next question?
Can anyone from my team can pull up the Google Doc, because I am having that Google Doc in different device. I mean, my computer is set for Zoom, and if I try to do something else, it's gonna.
No problem. When I think somebody may not be muted, so just remember to mute yourself if you're not talking. All right, so team one, let us know when you're able to share your screen. Any takers from team one, or should we find another team?
Come on, team one, please do it.
I'm just trying to figure out how to share my screen real quick.
Oh, sure, no problem. I'm sorry. I just didn't hear anything, so I wanted to make sure we're good. It's the fun part of using technology. Here we go. All right, excellent. Okay.
So for question 3A, please provide your sources for your clinical decision making for the previous two questions. So we use the NCCN guideline version, 1.2020 management for immuno-related therapies, related toxicities, specifically MS-24.
Okay.
Let me pull that up.
Yeah, and did you look at any other references within the guidelines? Because one of the things I wanted you to do was really investigate some of the individual references that the guidelines are based on to make sure.
Oh, we didn't get a chance to do that yet.
Yeah, I did it. I did it from.
Oh, you did? Okay.
Yeah. So what I did is like cross-referencing, like see what number of reference they have used and go to that reference.
Perfect.
And I find so many articles that just tells an alternative option, but
Yeah.
they just don't define why this is good option over other. Finally, I get the case report. This is what I'm talking about, that he pulled up for me, and
Perfect.
and explained the reason why IVIG is better than other. And I was about to go to the cross-reference to that information, and I ran out of time. But then, if you scroll down, there's the exact same case report I find that we're dealing with right now.
Yes, and this is in fact the case report, I believe.
Yeah.
Yep.
Yeah. And on page number 2, can you go to page number 2, hon, please?
Yeah.
Okay, so
yeah, I see that. So it's days 9 to 13, right? Right here. Yep. For a 5-day course. Now, this is actually where I got the case from. So it's a real patient case. And again, this is what was available and what was used instead of infliximab. But you really have, a choice. You can use the IVIG instead. It's just, I don't believe that IVIG is included in the guidelines explicitly. And it may just be because, again, it hasn't been studied. So
In
yeah,
practice, do you see IgG used a lot compared to infliximab?
no, I would say we probably use infliximab more just because oncologists are, they got on board with using it for colitis, and we don't tend to use IVIG for colitis. So I think their thought was, well, we know that the mechanism blocks tumor necrosis factor alpha, which is one of the main mediators of these, events in patients, regardless of what the kind of itis they have. So I think from a mechanistic perspective, it makes sense. And so they're more comfortable using that. Plus, we use it fairly commonly for a number of different disorders.
Oh, okay.
Yeah, but it's an absolutely, equally correct option.
They also placed that in discussion that they started treating 12 patients for grade 3 pneumonitis, and out of 5 they have to give additional treatment on steroids on top of steroids, and
right.
All 5 patients were treated with infliximab with or without cyclophosphamide. All 5 of them died because of infectious complications. So
right.
I kind of assume that giving infliximab on top of steroid is like you're trying to now suppress their immune system too much, and they die because of infection.
You're absolutely right. So that is probably one of the biggest rate limiting steps for giving a patient infliximab and or Cytoxan along with high dose steroids. So some of the things that we worry about with infliximab, we worry about potential risk of TB, right, and reactivation of TB. We also worry about potential risk of reactivation of Hep B. We worry about impaired response to viral infections and also invasive fungal infections. So we know that in our patient population in Fresno, for example, in the Central Valley, we have a high risk of disseminated San Joaquin Valley fever, right? So we also have to be really careful that anytime you're suppressing someone's immune system so significantly that you increase their risk of dying from infectious complications. So I think patient selection is probably really important, right? So in this case, this woman's 76, so she's older. She has, metastatic cancer. So her risk factors for developing an infection probably would be more substantial than somebody who maybe had a better status when they were first admitted. So I like that. I like that option a lot. Perfect. Okay, so then let's move on to question number 4. Let's say, how about team 9? And I'm literally just doing a Rolodex in my head, so I'm not doing this purposely.
Okay, let's see.
Oh, sorry, my dog is whining. While you do that, she doesn't like being trapped in the office with me either, apparently. I know. Okay, go downstairs. Go downstairs? Yeah, go downstairs. Alex, go downstairs. Okay. Go to mommy. All right. Sorry about that. Cuteness alert. She was playing. Okay. Ooh, this looks really fancy, you guys. All right. So you want to walk me through really quickly kind of how you came up with it? And I'm really impressed. This looks great.
So after talking to you really quickly, I want to ask you that question. We thought that if we were going to do it this way and we had to do something for grade 2, 3, and 4, then we would split it up to, in the beginning, it would be easier if they had what type of exams they would need to get first to check on the patient. And then after that, you would get labs done. So point of care labs are like the ones that you can do immediately right then and there. And then labs are like the ones where you have to send it in order, and those are the ones that take time. We haven't finished it completely, but these are some of the ones that we could use